So welcome everybody. This is really a number of events combined to one. First of all, I want to welcome all the speech pathologists who have recently set up in Harris Park near my practice, Speechify. This is why we started this. But then of course, COVID lockdown occurred and we couldn't do it face-to-face. So I thought we'd invite a number of other colleagues, and so there's welcome to all the speech pathologists and myofunctional therapists out there who've tuned in. Now, just a couple of housekeeping matters. During the lecture, if you want to ask a question, just put it in the Q&A section, so not in the chat section. The biggest mistake, people put something in chat. Chat is for you to chat amongst yourselves. It will not come to me, nor will I read it or answer the question. So Q&A, and I do the Q&A at the end of the lecture. The second admin point, if you want a CPD certificate for this event, you need to do a multiple choice exam, and that multiple choice exam is through a website which is called eodo.teachable.com. So point number one, I'm happy to do questions and answers at the end of the lecture. Number two, if you want to get an actual CPD certificate for this event, it is the EODO Teachable website that will offer you that. And it's a very simple Q&A, but we need to justify that you actually attended, listened, and learnt. That's the way we do the CPD. All right, so let's sort of start by some definitions. And really, I want you to understand that myofunctional therapy, orofacial myology, tongue thrust therapy, they're all talking about one and the same thing, depending on who you're speaking to. And the way I talk to parents of children who need this therapy, I say, look, your child's got a structural problem with their facial muscles. And a lot of this is really related to their airway. So if I send you to an ear, nose, and throat doctor who removes your tonsils and adenoids, you still need to learn how to breathe through your nose because you haven't been used to doing that. If you've had a tongue thrust, for so long because you're tongue-tied, after I release your tongue tie, you need to learn where to put your tongue. So parents don't understand any of these terms. They understand speech pathology, but then they get all offended when I suggest they attend a speech pathologist because they feel that their child has no speech problems. And most parents view a speech pathologist like an occupational therapist where they feel their child is delayed, and every parent doesn't want their child to be categorized as delayed. When I went through dental school, this is 36 years ago, I paid my tuition by being a swimming instructor. And I always remember when you line the kids up for the first day of the holidays where they'd be your students for the next 4 to 5 weeks, no parent would want to put them in the beginning group. And the way I would test, I'd literally get all the 30 kids to jump in the pool and swim to the other side. Those who nearly drowned clearly needed to go in the beginner group, but there's no parent who put their hand up and said, I want my child in the beginner group. So it's a similar sort of thing. So what I say to parents, listen, whether we do structural stuff like orthodontics and widen the palate, whether we release your tongue tie, or whether you have an airway resolved via the ear, nose, and throat, we need to train your child to change the muscle balance that currently is compensating for the problem. So they all understand physiotherapists, right? So I like to say that I'm sending you to a physiotherapist for the facial muscles, and that makes perfect sense. And at the end of the day, that's effectively what we are doing. Now, what I'm going to bring to the table here is chicken and egg scenario. Was the narrow palate and the mouth breathing causing the tongue to go in the wrong direction? Or was there a endogenous tongue thrust to begin with that's not stimulating the palate enough to develop the arch? So, which came first? Is it the craniofacial problems the kid had genetically, resulting in this, what we used to call adenoid facies, which is a open mouth posture, right? Or is it the tongue itself that's causing the problem? And that's where I think there'll be so much debate and no one will agree on one thing, because there's enough in the literature to really confirm both sides of the equation. Now, when you go on Teachable, there's a couple of articles and videos that are free for you to download, all right? One of the articles is this one, and I like using this when I lecture to speech pathologists, because at the end of the day, Linda is a speech pathologist herself, and she's a teacher in the Oregon Health Sciences University. And I think this paper is the best summary of what I'm going to teach you tonight. I want you to understand that what I'm going to teach you tonight is very evidence-based, but many of you may not read the literature in the evidence because it comes from ear, nose, and throat journals or comes from dental journals, and you're used to reading speech journals. So in this supplement, the author, Linda, has really gone through a very good review of the orofacial myofunctional disorders that constitute to things such as tooth development, facial development. She talks about airway obstruction, mouth breathing, improper swallowing, et cetera, et cetera. So when you go into Teachable website, you can download this information. So let me just share that with you to begin with. So number one, you'll have that article. Number two, you'll have this article. This comes from a language journal and not a journal that I would normally read, but obviously I've got a lot of colleagues who are in different specialties that share information with me of value. So this is a good paper. They look at children 2 to 6, which I think is the main focus of most speech therapists. And they ask the speech therapist to simply give the parent a sleep habits questionnaire, right? Because a lot of you will be dealing with behavioral disorder kids, maybe ADHD, maybe ASD, whatever. And none of the speech paths that I work with, until they do some further courses like this, understand that there's a huge link with that child's breathing, their craniofacial development, and their sleep. So in this paper, what they showed is that of 51 children who were given the survey, 31% screened positive for sleep disordered breathing, 78%, which is 40 out of 51, for behavioral sleep problems, and 43%, as per the parent report. So it just shows you that integrating sleep problems and the screening of that into speech language pathology practice is very feasible and could widen the surveillance of both sleep problems and risk factors for developing language disorders, right? So that's an important role why you, I shouldn't say ladies, because there are the odd male speech pathologists, but in all the places I've been to, I think they represent less than 1%. So for any speechy out there, what I'm going to teach you is in your literature. In Linda's paper, your literature, this paper, your literature, right? So I'll share those with you so that you have some evidence. Most speechies get so worried about, what's it called? Scope of practice. And should we be doing something outside of our scope of practice? What you're doing, you're part of a team here. So we're not asking you to remove the adenoids and tonsils after a 1-hour webinar, right? We're not asking you to release a tongue tie after a 2-hour webinar. We're asking you to be aware that if you're doing hour after hour, month after month, week after week, speech pathology and it's not working, look as to why it may not be working. You know, have you looked at the tongue tie? Do you know how to look at a tongue tie or a lip tie? Do you know how to examine a normal airway and ask the right questions? Okay. The other thing you'll see in a lot of these kids, and again, it's 2 to 6, and that's an age group that I do a lot of interceptive treatment because that interceptive treatment has been shown to be of great benefit for craniofacial growth at that age because the kids have a lot of growth of their facial complex at that age. Now, this comes from a pediatric dentistry journal. So you as a speech pathologist probably would not have this on your reading list, but it talks about the palate and otitis media. So a lot of your children that you see every day will have what's called recurrent otitis media. And that simply means middle ear infection. So what you realize when a child has a narrow palate and they swallow incorrectly, the palate is not stimulated to elevate the two muscles, tensor levator palatini. And they're the ones that connect to the eustachian tube. So do this yourself. I want everyone to swallow. And as they swallow, you'll hear a little pop in your ear. That is the eustachian tube being cleared. And a child who has a nice palate and a normal tongue posture, breathes through their nose, lips together, tongue on the palate, they will have less otitis media. And this paper will explain why. Obviously, I will go through that in more detail. But I want you to understand, young children, eustachian tube is parallel, so it doesn't actually drain naturally. Only when their face height increases do you see what I'm showing you there. And the other thing is, if you just look at the shape of the palate, I'm going to teach you how to measure that distance in between the molars. The adult molar, called the first molar, erupts by 6. So there's measurements to look at the baby molar distance, which is what we're showing you here, and also the adult molar distance. And that measurement gives you some indication whether your patient that you're treating for speech pathology may in fact have a narrow palate. Okay? So that's paper number 2. Then we have this paper. And again, from a pediatric journal, this time a medical pediatric journal. And it talks about certain tests you can do on your kids, because a lot of you will have the little boy on the left with correct treatment, which includes airway, widening the palate, and myofunctional therapy / changing tongue position. And another thing I can add to this term is mewing. If you Google the word mewing, mewing is really a summary word for putting your tongue on the palate, breathing through the nose, lips together. And if you can do that early, and many kids can't because they can't breathe through their nose or they're tongue-tied or their palate's too narrow to do. If you do that early, look what happens to the face. Look at that boy's change in just a short period of time. And again, the early time to do it is in the maximum growth spurt of those jaws. So I'm going to give you this paper as a little summary of what to look for. And it's well within your scope of practice. You're not actually pretending to be a dentist, right? Nor am I pretending to be a speech pathologist, but I work with people in my rooms who are dual qualified. They've done language and speech as their primary degree, then they've gone on and done further qualifications in myofunctional therapy. And they're fantastic because they pick up the interrelationship. And remember, most of these kids are coming to you because someone's identified a problem as they're getting ready for school, right? In the same way, one of the problems as they're getting ready for school is poor sleep. Because if a kid's not sleeping well, how do you think they're going to perform when they go to class, right? So that is a good dental summary paper for you. So let's start with a little video. And again, I'm going to give you a copy of this video in your download notes. And this is from Dr. John Mew And it talks about how a palate develops and what the role of the tongue is in that.
A normal upper arch should look like this. It forms that way because the tongue rests in the area between the upper teeth. There, it counteracts the pressure of the cheeks, which would otherwise push the upper arch of the jaw in. But if a child sucks his thumb or breathes through his or her mouth for any reason, then the tongue drops from the top of the mouth and the upper arch can get pushed in. The narrowed upper arch has a knock-on effect on the lower jaw, forcing it further back and down.
So if you see that jaw pattern in your kids, that's not normal, right? So that's called a class 2 jaw. I'm going to get you to start measuring that intermolar distance just as a guide on your kids. And can you see the important role of the tongue? If the tongue sits there, it counteracts the negative forces of the buccinator. But if the tongue's not there because the kid's got a tongue thrust or a tongue tie or sucks their thumb or can't breathe through their nose or all of the above, then what's going to win the war is the buccinator. And that's when you start seeing this narrow palate. And that's when it's very hard for you to do the normal speech pathology exercises you would do. And when I graduated 36 years ago, that's the age I would treat kids. And what would I do? Quite foolishly, I would pull out teeth to make room. And as I pull out teeth and straighten their teeth, guess what? I'm making their jaw narrower, I'm worsening their tongue position. And we now know that can have a roll-on effect in sleep apnea because the tongue needs to sit up on the palate so that it opens up those pharyngeal wall muscles. And the oropharynx is an area that dentists look at and speech pathologists should also be acutely aware of. So we'll talk about those things. But, we want our kids to have their tongue sitting up there. Now, when the tongue sits there, it stimulates growth of the upper jaw called the maxilla via a process known as intramembranous ossification. Intramembranous ossification means the tongue is hitting those sutures, stimulating them to grow. There's been numerous experiments to show that without proper function, normal form doesn't occur. And normal function is tongue on the palate, breathing through your nose, lips together. That's the way nature intended it to be, right? So that's one video that I want you to, show your parents. It's a great way to describe what you're actually going to be doing in your therapy, et cetera, et cetera. And I have always an open invitation for speechies that when they've read the articles and they get a bit more understanding, feel free to contact my PA and come in for an observation visit when I'm doing new patient exams. Or if you have a patient you want to refer in, come in with that patient because it gives me the opportunity to show you practically in that kid's mouth what I'm looking at. And then all of a sudden, you'll see the benefits of looking outside of just your training as a speechy. Just like I say to dentists, look outside your training just as a dentist and start looking at airway problems, et cetera, et cetera. So we divide the malocclusion, right, which is a bad bite, and oral dysfunction into a number of factors. If you don't breastfeed in an upright position for at least 6 months, you have a higher chance of your palate not developing correctly, and your tongue then develops what's called a downward forward position because it's not used to stimulate the compression of the nipple. If you can't breathe through your nose for whatever reason, allergies is the most common, you're going to develop a lower tongue posture. And that mouth breathing can result in what I showed you on the video. Then we have oral habits. The most common are thumb sucking, but add to that pacifier use, add to that blanket sucking, et cetera, et cetera. Then we have the impact of chewing. Most kids now are bottle fed. They then go to sloppy baby food. They're not like primitive man who used to try and gnaw on a bone from early, because chewing stimulates the development of the muscle. So nutrition and chewing is another aspect of that, right? So you hear the term myofunctional therapy in your field, in speech pathology, and basically it focuses on the muscles of the face, the muscles associated with swallowing, and it's just like physical therapy. But it helps my patients to make a mind to muscle connection so they can gain better control over that abnormal movement. Resting position, remember, is equally as important as movement, because if your tongue doesn't rest in its normal position, I showed you in the video, you're not going to get normal development. So in that original paper, we talked about how speech pathologists can help to diagnose sleep apnea. But when I say help, diagnosis of sleep apnea comes from a sleep study and it's done by a sleep physician. But you could point that parent in the right direction to get the sleep study to get the right care. And if you look at what you see in these kids, they will have repeated arousals during their sleep, which means they're less attentive and they could have what's called attention deficit disorder. Snoring, and I'll give you the name of a app that any parent can download that's free of charge. Because when I ask a parent, does your child snore? They're going to say, I'm not sure, he sleeps 2 bedrooms down the hallway and I don't hear it. So you can get a free app on any smartphone, which is called Snore Lab. And this app you put next to the child during their sleep and it'll record if they're snoring or labored breathing. The other thing you can do is you can put on their thumb a little pulse oximeter, and that will tell you if they're desaturating. In other words, if their oxygen saturation, which should be 99%, drops dangerously low to anything below 90. A 4% reduction is known as a desat. And this is something that you can do without a sleep study as an alert way of picking up the problem. Now, why is this important for you as a speech pathologist? It's important because look at the age group that sleep apnea is most prevalent in. It's the preschool age, the age that you're working with. And I know that in your undergraduate studies, wherever they are, you may not have been exposed to this. And it's only because you are learning so many other things in your profession, but slowly, you're probably at the stage of your career where you're saying, hey, every second kid snores. Every second kid is an open mouth posture. How does this affect me and what I do? And I'll come to some really key slides, which I'll say to you, hey, take a photo of that slide now. There's one slide that talks about which speech sound is affected by the type of malocclusion, which is an important one for you. But can you see what's going on here? Your age group of kids you're seeing with speech pathology are the same age group that have airway problems. And I've already mentioned this paper, great research with a cohort study from the USA. And if you look at their conclusions, circle those for you. The prevalence of sleep problems in the 2 to 6 year olds that present to speech language pathologists was much higher than in community samples, right? But consistent with data from young children that have developmental disabilities. So I think you should at least screen in your consults for these sorts of problems. And 2 ways of screening are asking questions, and the best questions to ask you can download on a questionnaire known as the Bears questionnaire. Just Google Bears questionnaire, the paper's there. It's a series of questions that the parent answers, and the more the answer is yes, 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 the higher risk factor they have. Then you've got the pulse oximeter to check their oxygen desat. One of those machines is $60, right? Very easy to loan to the parent. It's not a sleep study, but it's a way of getting the parent on board that there is a problem with their child's breathing and hence tongue posture, blah, blah, blah. And the last thing, of course, is the Snore Lab app, right? So you're not paying millions of dollars for those bits of kit. And why is it important for you? This is a meta-analysis published in a sleep journal, and you'll hear me talk a lot about this guy. His name's Zaruf Zaghi. He is a dual qualified ear, nose, and throat sleep surgeon, and he is the master on tongue tie release. And as part of your download notes. You will get a paper by him, which talks about how to examine the tongue to properly assess for a tongue tie, which is a good paper. And although it's not part of your course download notes, if anyone's interested, if they send me an email, info at my name, no E please, right? .com. So one word, info at derekmahoney.com. And just say, could you share with us the videos from Dr. Zaghi? Zaghi has a series of 5 videos that show you how to look for lip tie, tongue tie, how then a proper release is done, and how you as a speech path do exercises before the release, straight away after the release, because it's very, very important. And he's got the best evidence-based literature to support that. So I'll give you his paper, but it's also good for you to look at his videos. Now, sorry, just delete all that so you can read that slide. Okay, so what is this paper telling us? It's saying that myofunctional therapy, which is what I'm talking about, decreases the apnea-hypopnea index, which is the way we assess in a sleep study if a kid has sleep disordered breathing and or sleep apnea. It can reduce it by 62%, which is amazing, right? And these are the kids who have the snoring, I've already mentioned, the low oxygen saturation, and they're going to have things like hyperactive problems, because when a child doesn't sleep well, unlike an adult, if we don't sleep well, we're tired, we're lethargic. If a child doesn't sleep well, they end up sort of climbing the walls, right? And it's mainly the teachers, unfortunately, that are pushing parents to get their kids tested, not tested, but put on Ritalin. But no child should be put on Ritalin until they have a sleep study. That's very important. So if you have one of your patients now that is diagnosed with, all these spectrum disorders, ask the question, did you get a proper sleep study? Because that's an important aspect of care. Another paper here discussing that there's a direct relationship between the tongue protrusion force and the maxillary inspiratory pressures. So therefore, remodeling of the upper airway is all about the tongue. And your role as part of your speech training is to put that tongue in the right spot. So there's really 3 things we look at here, right? Number 1, we want the palate the right shape, right? Number 2, we want the tongue to be able to move properly. And then your job is to train the kid to put that tongue up there. And how can they put that tongue up there? They need to put their lips together, right? Do some exercises of strengthening the tongue. And I can show you lots of links and videos to learn those exercises. There's lots of great courses if you want to learn more about this. But tongue thrust, even though I'm talking about it a fair bit here, it's actually a small part of the equation. Airway is the main focus, right? And we need to realize that when we have children who have poor sleep, open mouth posture, who snore, they also have a poor tongue position. And we need to help them in a multidisciplinary way. My involvement, I have training in sleep medicine and I have training in orthodontics. So my training in dental sleep medicine is what allows me to refer the kid for a sleep study, to analyze that sleep study data to see if they're grinding their teeth at night, to see if they are desaturating oxygen during their sleep. I then have my orthodontic hat on to see what type of malocclusion they have and whether that type of malocclusion is common in this problem. So I get a lot of speech pathologists who refer me patients as a co-treatment, in that they're trying to achieve X, Y, Z. And particularly, I love working with speech pathologists who also have OT training, because they're really switched on individuals and they see straight away that 80% of their clients actually have both of the problems. So I won't talk too much about orthodontic treatment, because if this was a lecture to dentists or to oral health therapists, I'd be talking more about that. but this is a lecture more designed for speech pathologists, so I will mention it so you understand the terms. Now, the term myofunctional therapy, it's not a specialization, okay? So anyone can give a kid exercises. A parent can be a myofunctional therapist. But really, in the clinical scenario, it's normally dental hygienists or oral health therapists. It's definitely you people, the speech pathologists, or I think you call yourself speech and language pathologist, something like that. And of course, doctors and dentists. And in my case, specialist doctors, specialist dentists. Now, I'm not going to bore you too much with literature because I want to get on to some clinical stuff. But if you look at all the papers, which are in your downloads when you go to the website, they all talk about a kid who can't breathe through the nose, seeing an ear, nose, and throat. Fair enough. But when you look here, after children have their tonsils and adenoids removed, 72% of them still have residual sleep disordered breathing problems. So what they don't take into consideration is the need for orthodontic therapy, right? At an early age. So most of you think, oh, I only send my kid to the orthodontist when they're 13, 14, when they've got adult teeth. Yeah, that's if you want to straighten their teeth. Here we're talking about a whole different goal. Here we're talking about facial development, what we call dentofacial orthopedics, right? And in fact, I'll add one more paper now that I've just thought of it into your lit review. Let me just get that right now. I hope it's here. Yeah, the Bears questionnaire. I'm going to add that into your tools. So all of these you'll be able to download at the on the website. Now the website, just so we're all clear, they'll have all these papers for you. Is eodo.teachable.com, right? So eodo.teachable.com. And you'll go in there, you'll see the section for speeches. It has the videos, it has the articles, everything you need to get you underway. But as I said, put theory into practice by coming in and watching me treat these kids, consult the parents, and you'll see. I did my initial training as a dentist, then I did specialty training as an orthodontist. I then realized there was a huge correlation between the malocclusion I saw in kids and their airway. So then I did further training in dental sleep medicine. So I have really 4 degrees: dentistry, orthodontics, dentofacial orthopedics, and dental sleep medicine. And those 4 degrees helped me to put it together to link the different fields and see the commonality. And I've just recently completed my PhD research, which looked at children between the ages of 7 and 9 who had sleep disordered breathing. And we looked at a number of factors, including what percentage of those had previous speech therapy, what percentage of those had bedwetting problems, what percentage of those had a bad bite, et cetera, et cetera. So it's something that I'm very passionate about, right? So in this paper, they showed that 25 children who had adenoids and tonsils removed, and then they had another group who had the expansion of the palate only, and they had a third group that had expansion of the palate and the adenoids and tonsils. And which group do you think had the best improvement? Well, it was the ones that had the expansion and the adenoids and tonsils, but they actually didn't have the best resolution that's possible. The next paper showed that the best resolution possible were the kids that had airway resolved with an ear, nose, and throat, arch expansion, and then had myofunctional therapy. So you see where you come into the equation. You can help in the diagnosis of the problem, but you're definitely involved in the treatment of this disorder. Now, what do we know from adult studies? Well, did you know one of the best ways to treat sleep apnea is to learn to play the didgeridoo? And why is that? Because you're using the muscles, or you're exercising those muscles, you're strengthening those muscles that would normally collapse during sleep apnea. And here's another paper, also published in the Clinical Journal of Sleep Medicine, where they looked at the respiratory muscle training in people who use different wind instruments, okay? What they found is that musicians who played a double reed instrument had a lower risk of sleep apnea. So, there's a lot in the literature to make you understand that muscle retraining is important. And the conclusions of this paper, oropharyngeal exercises significantly reduce sleep apnea severity and symptoms. So it's a good treatment modality. Not the only treatment modality, but now, I won't mention too much about the exercises because each group has its own magical exercises. But the basic exercises are anything that strengthens lip seal, anything that encourages nasal breathing, anything that encourages the tongue sitting on the palate. So my dual qualified speech paths oral myologist, they put a little stone adhesive wafer up on the spot here, and they get the tick to put their tongue there, right? And then they lick that, and normally that's in the mouth for 45 minutes, and they're strengthening the tongue, but they're also developing the palate, all right? In Italy, a very famous doctor, Dr. Bertarini, he helped lots of kids who had Down syndrome, because those kids are always like, right? To obtain a reduction in their mouth breathing by doing these oropharyngeal exercises. And, we know that those exercises help improve oral breathing versus nasal breathing. They reduce the snoring. And as I said, there's numerous exercises. And again, if you want to watch some videos on those exercises, I'll recommend a number of websites. But it's not as though there's just one exercise, but they all kind of lead towards the same thing. And the reason speech pathologists are good at these exercises is because you see the kids sometimes on a weekly basis. Whereas I, as an orthodontist, see them every 6 weeks. A general dentist sees them every 6 months. So who do you think is best equipped to monitor these exercises and to motivate? So your role is really through education of the parent of what's going wrong, motivating the kid of what they need to do, and then the compliance follow-up. And that's a very important role. I work a lot with speech pathologists in that regard. This is a paper by one of the supervisors in my PhD research, Dr. Maria Villa, who is a very talented pediatric specialist in Rome, Italy. And in this paper, she shows that when you looked at kids who had a persistence of airway problems after they had adenoids and tonsils, and one did nothing and the other did these exercises, the group that did the exercises had a significantly higher reduction, which is like 58% versus 7%, right? So lots of those papers for you to read. So what's my topic at the moment? If you can help your patients to be diagnosed with the wrong posture, i.e. mouth breathing, i.e. lower tongue position, and you can help to re-educate them, then the earlier you do it, the better. But some of your re-education would need help from me to widen their jaw, help from the ear, nose, and throat doctor to clear whatever it is that can't allow them to breathe through the nose, all right? He's the father of sleep medicine, Christian Gumano. He passed away 18 months ago. And what he was saying is that myofunctional therapy or re-education with children who had sleep disordered breathing was extremely important if you were going to get a complete reduction in their apneic index, et cetera, et cetera. So Joy Moeller is a name that will come up a lot. She runs great courses for speech pathologists to learn how to do myofunctional therapy. A lot of those are online. So if you just Google her name, Joy Moeller. And the other lady who is trained by Joy, who's more local, her name is Nada Karnib. And at the end of the lecture, I'll put her email up for you, because you want to be taught by someone from your field, because they can answer all those millions of questions you may have from a speech point of view. But look at this data, right? That you're getting such a huge reduction in these problems with your children. So here's an open question. Can myofunctional evaluation help us to recognize early a child that has sleep disordered breathing? Absolutely, yes. Can early intervention prevent oral breathing and sleep disordered breathing? Absolutely, yes. So the question is, how early can this be started? Well, let's start by looking at the medical history. Are these kids on medications that would alert you to, they're taking melatonin? That means why? They're having problems with sleep. They are taking Osmolax for constipation. That's a high risk because they have gastric reflux. They have recurrent antibiotics for middle ear infections, et cetera, et cetera. And allergy is the big one. I have a podcast, and if you speak to my PA, Naz, so her email is just pa@myname, derekmahoney.com, right? She will give you access. It's a free podcast. I interview on that podcast people in this field. There's about 15 we've recorded. And one of them is a ear, nose, and throat doctor, Larry Kalish, who is very, very good at allergies and treating allergies in kids, particularly dust mite. So I think every second kid you will be treating would have allergies. So what can you do about allergies? Well, you start with the basic stuff, which is nasal rinses, then you move on to the sprays. But then if you try to eliminate everything and that's still not working, then you move on to immunotherapy. So he's got a great podcast where I interview him, where we discuss that. But basically anything that can cause stuffiness or nasal congestion is going to be your enemy. And that could be a deviated nasal septum, large inferior turbinates, large adenoids or tonsils, et cetera, et cetera. And remember, I deal with patients for dental problems. You deal with patients with speech problems. Ear, nose, and throat people deal with children with breathing problems. But guess what? The mouth is where it all begins. And, you've got to use your nose for breathing, not your mouth. And many parents just don't get that. Sometimes I almost have to say to parents who look at me with a blank expression, why are you interested in my kids' sleep and their breathing? I thought you're just the mouth guy. I say, listen, would you be worried if your kids started putting their food up their nose, right? And of course the parents say, yes, I am. Well, the nose is for breathing. The mouth is for eating and for speech. So if you understand oral habits are not good, mouth breathing is not good. And even as a baby, our first experiences are using the mouth. So the questions you should be asking your young kids, or their parents, I should say, did they have any troubles feeding as a baby? Colic, not being able to latch on. Were they bottle fed versus breastfed? I've already talked about whether they've had grommets placed. That's that recurrent middle ear problem. Have they had digestive upsets? Because that again talks about that intrathoracic pressure not being correct because they're mouth breathing versus nasal breathing. Second question I ask is about habits. Did they suck their thumb or finger or a blanket? Did they use a pacifier past a certain age? Do they do certain habits like, a weird noise with their tongue? Do they bite their nails? And we can eliminate those habits via a number of factors. This is my go-to one. This is called a thumb guard. You put it over the kid's thumb or finger. The kid can still put it in the mouth, but they lose the vacuum, so it's not comfortable anymore. The other thing is to put an appliance in the mouth that widens the palate so the kid physically can't get their thumb in the mouth. So what I ask in my orthodontic consults is any history of speech therapy, because that alerts me straight away. The most common difficulty is going to be a lisp, both anterior and posterior, and we'll talk about anterior and posterior tongue ties later in the lecture. Also, ch and j are very common. And general precision, you know, the T, D, N, and L all require precise movement of the tongue. So, you know, we're getting a lot of these kids that mumble, they have general lack of clarity, very little facial movement as they articulate. Then remember snoring, and just to remind you again, you won't be able to sleep next to your kid every night for a week, but you can pick up abnormal noises such as bruxism, such as snoring, using that app, right? And the big question, you know, does your kid have autism spectrum disorder? Do they have attention disorder? Do they have attention hyperactive disorder? You know, all of these things are high indicators that they need to get a sleep study, and they may need to then have their palate widened and do myofunctional therapy, plus or minus ear, nose, and throat involvement. Please understand, a child under 6 should never snore, right? Child who snores is normally in the lower percentage of IQ in the class, and I can quote you all the research on that. You know, when these kids are grinding their teeth, what they're really trying to do is bring their jaw forward at night to open up their airway, and they can get more oxygen by moving that jaw. And there's lots of studies in the literature that show a lack of oxygen in kids is related to all those disorders I've talked about, including bedwetting, etc. So I teach all my students who are learning orthodontics to look in the back of the mouth, behind the tongue, and we look at two things. One is a grading of the palatine tonsils as outlined by Brodsky. And normal is if you divide, so you just get the kid, push the tongue down, look at the back of the throat, and you divide it into quadrants. So that's the midline through the uvula. Then you have either side of that. Then you divide that in the middle again, okay? Now, as you divide it in the middle, what can you see? If the tonsil goes past that midline, that's grade 3, you get it? If the tonsils are hitting the midline, sometimes what we call kissing tonsils, then that is grade 4. Both 3 and 4 need an ear, nose, and throat evaluation. And that's regardless if the kid has infected tonsils. So I'm not talking about tonsillitis. You can have large non-infected tonsils contributing to this problem. And here's another thing I want you to really be aware of. And, you know, you could be a lifesaver in picking this up early. If you have a kid who has a unilaterally enlarged tonsil, so one side is massive, the other side is normal, that's a high chance of a lymphoma in the mouth, okay? So please look at the tonsils. We as orthodontists take x-rays and we can look at the adenoids. You can't see the adenoids in the mouth, but if you get the kid to say, you look at their soft palate, and if their soft palate can't elevate, that's probably because the adenoid is right on top of that soft palate. The other thing is that kid will be very nasal in their speech, even without a head cold. So rather than say banana, they'll say banana. Does that make sense, right? So if you don't do anything while the kid's young, they end up needing CPAP therapy or oral appliance therapy, et cetera, But while they're young and their jaw's growing, we can help that jaw to grow forward, which opens up that posterior airway space. Because giving them devices like this after the damage is done is not really good quality preventive care, right? So look at your kids. You'll be able to see their posture, and forward head posture is a classic if they're a mouth breather. Second, look at their tongue. That's a classic tongue thrust, you know? So for $5, you can buy these plastic retractors, you put them either side and you do this, and then you get the kid to swallow. You won't see a tongue thrust if you just get the kid to swallow normally, because very cleverly, the tongue forms a seal with the lower lip. It's called a tip of tongue to lower lip swallowing pattern. So if they're a mouth breather, they're a tongue thruster, right? Both are symptoms, but they're smaller pieces to a bigger puzzle. And that bigger puzzle relates to the growth of their palate, to their sleep, and to their nasal airway. So they could have a gap between their front teeth. Now, I'm just sort of making this very user-friendly for speech pathologists. I apologize if there's any oral health therapists or hygienists, because this would be like teaching you to suck eggs. I'm sure you understand this, but it's important for our colleagues to understand what is a class 3 jaw, what is a class 2 jaw, what is an open bite. So these 3 bites are the most prevalent that you'll see in your kids that have these speech problems. Open bite means their front teeth can't touch naturally together. Overbite, which means the front teeth are very forward of the lower teeth, and underbite, where the lower jaw is bigger than the upper. Now, the patient that has the underbite, the most common is because their maxilla hasn't grown forward enough, right? So they're a high risk of airway problems in the velopharynx area, and they'll have sound pronunciation associated with that poor velopharynx movement. Kids with an overbite, their lower jaw is too far back, and same sort of story, you'll see their digastric doesn't perform correctly, and I'll go through some of the muscles that we look at. So just to give you a review dentally, a normal bite is just like a shoebox and the lid. You put that lid over the shoebox and it fits perfectly, just 1 millimeter, 2 millimeters over the box. That's what a normal bite should be, right? So this is your upper incisor, that's your lower incisor. They meet just over by about 1 or 2 mils. But if they don't meet and there's an open bite there, the tongue's going to get in there. And you can see that here in these diagrams. Let's talk about tongue tie, right? How can you properly diagnose a tongue tie? And remember, reach out to me by my email, and I'm happy to give you those videos by Dr. Zarush Zaghi, because they're absolutely fantastic for you to help diagnose this problem. Well, number one, when you get the patient to open their mouth and say, the tongue will form a V, right? Number two, the distance from the tip of the tongue to the insertion of the frenum should be ideally greater than 16 millimeters, right? 8 to 16 is considered normal, but not ideal, depending on it. Under 8, 100% needs release. That's one measurement. The other measurement is the measurement by Audrey Yoon, and that is the measurement where you put the tip of your tongue up here and you open as wide as you can. Now, if the kid releases their tongue, less than 50% of their opening, that's a functional tongue tie, known as ankylosing, right? So it's really important that in your exam on all your speech patients, you do that 2 tests. The Kotlow test, again, one of your papers, which is the measurement from the insertion to the tip of the tongue, and the functional test, which is by Audrey Yoon, right? So the paper by Yoon, the paper by Kotlow, because it's really important you pick up these kids early, because if you don't, then that tongue is not doing its job. Now let's talk a little bit more about tongues by showing you another video. Which talks about mouth breathing and its impact.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso- and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches.
So, important thing to note, when you breathe through your nose, you can't overbreathe. The cilia in your nose helps filter the bugs. Then you get it humidified through the turbinates, so you get the right temperature, the right volume, blah, 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 right? When you choose to mouth breathe, then your body has to overwork. And the major defense of that is the tonsils and adenoids. They're the lymph nodes. They're like the filter in your air conditioner, and they're the ones that are going to absorb all these bugs. And when they swell, then the child adopts an open mouth posture.
Reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down.
Now, this is where the orthodontic part comes in. So you should be measuring that distance between those first molars, and ideally that measurement should be 37 millimeters. I'll come back to that. If it's a lot less than 37, higher chance of that kid having a narrow palate.
Well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth, and your tongue resting on the floor of your mouth, with the tip of the tongue between your front teeth. That is called an open bite. As your upper and lower
And that is what you would normally call a tongue thrust and what parents would say is a lisp, right? So the question is, have we looked under the tongue to see whether it can go up? Is this just a habit from many years of using a pacifier? Or is the palate so narrow that we can't get the tongue to fit? That's the million-dollar questions we have to answer.
Or front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
And, when we talk about this era of so many kids having poor sleep, it's a high correlation between their mouth breathing and the poor sleep. And just kind of remembering that whole concept that we want to be able to get the tongue on the palate. That's where you people come in to do that. There's just what I've got that open. I've added the Bears questionnaire just so you don't have to look for it on the internet. But basically, it's 5 major sleep domains. B is for bedtime issues. E is for excessive daytime sleepiness. Then we have the awakenings during the night. We have the regulatory and the duration of sleep, and last, what I talked about, which is the snoring, right? So basically, you're looking at the toddler preschools. I think most of your patients are that age group. That's what we want to kind of look at. All right, so getting back to where we are, if the tongue is no longer able to fit properly where it should, where's it going to go? Further back in the throat. And that's where we start getting the sleep problems. So this is a kid who has nasal obstruction problems. She has very large adenoids. She brings her head forward to help open up her airway. And of course, she's then going to get some problems where she'll be seeing probably a chiropractor for lower back pain, et cetera, et cetera. So look out for that. So people say, well, what causes these symptoms? I don't think there's one particular cause. Some people, mainly the medicos, call this an infantile swallowing pattern. And that is all babies have a tongue thrust. That's how they feed when they're on the breast. But some children tend not to grow out of it. And one possible reason is because they had difficulty in feeding, or they had colic, or they were bottle fed versus being breastfed. And remember, the ideal time to breastfeed, if you want to minimize problems, is 2 years. But national research has shown in Australia, the average time a child would be breastfed is less than 1 month. So big change, isn't it? WHO says minimum 6 months, ideal 2 years. In Australia, if you ask the question, you find it's a lot. That's why parents have to go to work. So it's not possible to breastfeed. And even if you express milk, that's only improving the immunological benefit of the milk. But the kid is given that expressed milk in a bottle, and the teat of the bottle puts their tongue in the wrong position. So that's important to know. Then you have sucking habits, very common in kids, whether it's the finger or the thumb. And remember, if you break the habit, just like if you clear the airway by removing the adenoids and tonsils, that doesn't guarantee that you're going to change the way those muscles are behaving, right? So you need to change that swallowing pattern. That's what myofunctional therapy is about. So remember, thumb sucking is definitely going to lead to a tongue thrust. And a tongue thrust leads to the open mouth posture. So that all of them are really interconnected. So cause number 3 is the airway being the number one thing. And that's what I subscribe to. I see that the most common things. And the most common in that subdivision is allergies. So please listen to my podcast with Larry Kalish. He'll explain how we can deal with that. But here's a kid that I look in their mouth. Here's a quick quiz. I kind of Zoom lecturing is so boring because when I'm interacting with an audience, I can see if you're awake or not. I can ask you questions, see if you're getting it. And one of the questions I currently ask people, hey, tell me after the last slide of the Brodsky index, are these tonsils grade 1, 2, 3, or 4, right? And the answer would be, let's see. Someone's maybe put the answer in there. Yep, very good, Alicia. They are hitting the midline, so they are grade 4. Excellent. But imagine if this one was normal. Oops, put that in. Where is it? Imagine if this one was normal and then the other one was like, that's a dangerous problem, right? So whether it's enlarged tonsils or enlarged adenoids or chronic nasal congestion because of sinus or asthma, all of these are causing problem. And the fourth is the tongue, right? Is it tongue-tied? Is it restricted? And why does that matter? Because as I said, growth and development are impacted by that. So I find as an orthodontist, if I have people who have a poor tongue posture, they're going to be longer in therapy and the end result is not as good, plus the stability is not as good. We want to understand that muscle control is very important. And that's from eating to expression. It kind of relates to the entire body. Now, please don't let your orthodontist or dentist ever put one of these in your kid's mouth, because this is just nonsensical. This is what we used to do to stop the kids sucking their thumb. I call it the Hannibal Lecter appliance. I have one of these still in my consultation room just to show a parent and a kid to scare them, right? But I wouldn't put this in there. Why? Well, you're creating another problem. Sure, the thumb can't go in, but guess what? The tongue, which wants to sit there, is also affected. Does that make sense? So if you're going to put any form of crib or rake, we put it behind the lower incisors because the tongue can't be sitting down there. In the palate, keep it free. In the palate, we use a thing called a myospot. If you just Google myospot, there's some great videos to show you how to use it. It is a material that sticks easily on that palatine rugae. The kid can then train to put their tongue up there. That's all you need in the palate. In the lower, either behind the teeth, I can put some what's called habit spikes, or you can put one of these, but don't put it in the upper. If you have any kid who's seeing an orthodontist has that in the upper jaw, automatically your life is made more difficult, right? So we talked about the term class 2. That's a class 2 jaw. Can you see the lower jaw set back? We turn to the class 3 like a Jay Leno type look. But the biggest problem in class 3 is the maxilla or the mid face hasn't grown forward properly. So when you see a child who has a class 4, what's class 4 mean? Class 4 means if this is the ideal position of the face and the upper jaw should be here and the lower jaw there, a class 2, the lower jaw will be here. You understand? A class 3, the upper jaw will be there. But if you have both the upper and lower jaw too far back, that's called a class 4. They are 100% your airway problem, speech problem kids. Now, how do you measure that? Your friendly orthodontist takes a side x-ray and we can map that out. But if you look at this girl, look where she starts. She's got that classic open mouth posture, right? She's a mouth breather. After doing some myofunctional therapy, after releasing her tongue tie, and after widening her palate, big change in that girl. So what we want to do is close the open bite. This is a thumb sucker. You might break the thumb sucking habit, but the residual problem is the gap between the teeth, the open bite, the tongue's going to get in there. So we also need to retrain that. Right? I won't talk about adults. I deal with a lot of adults, and mainly their problems by not having this treatment early is snoring sleep apnea and TMJ problems, right? But for your kids, we're really talking about foundation treatment, working with your orthodontist and helping that facial growth to occur. So that paper, where I give you that evaluation, there's certain scores, right? So what you do a checklist. Part of the checklist is, do they snore? Part of the checklist, are they tongue-tied? Part of the checklist, what's the width of their palate? And based on that, the more they have a high score, the higher risk they're going to have and the higher need they're going to have of myofunctional. So this is called a myofunctional evaluation form. It's in your course downloads. Anything greater than 11 definitely needs treatment. And that's a really easy score for you to do at your initial consultation. Does that make sense? Now, I'm not going to launch into the airways of the muscles and everything like that. But just to let you know, the number one muscle we need to help retrain is going to be the muscle connected to the hyoid bone, right? Because if you look at that muscle and you look at what it does, it recruits a lot of the other muscles. So I talk about the number one muscle being the genioglossus, I think, and then geniohyoid. And I'll explain to you why that is. Because we need to get those working with us to get the jaw in the right position and get the tongue up onto the palate. And there I just listed the frenulum. Now, excuse me, one of the exercises I do in my practice is using what's called a myotalia. So it's a little device where after I've checked for tongue tie, after the upper jaw is widened, and after you start your speech therapy, I get the kids to do this. And it has everything in one. It has a lip trainer, which you see here, to help strengthen it. It's the equivalent of putting a credit card between the lips and getting the kid to hold it in there, or in the old days, sewing button on a string and the kid having to pull that button out of their mouth by the other kid using it. So in other words, you used to get two kids, you put two buttons, tied them with string, both kids put the buttons in their mouth, they have to try and pull to get it out of the mouth. That strengthened their lip. This is doing the same. Then we have this thing here where the tongue sits up on the palate. And then we also have the strengthening of the jaw and the throat muscles. So this is what I use. It's called a myotalia. And I think I have a little video to show you. It helps post nose and throat work, transitions a kid from a mouth breather to a nose breather. It really helps with lip strength and seal. It improves those tongue strength of the muscles I just went through, particularly the strength of the suprahyoid muscles and the pharyngeal muscles. And you use it 10 minutes twice a day. So pretty easy to get the kid to follow those exercises. Now, I have a couple of videos on this, which I'm happy to share with you. Just email me. This is one of the videos.
Myotalia is MRC's latest treatment system and is the world's first combined active myofunctional appliance range. The appliances are designed for patients who present poor muscle tone in the tongue, lip, jaw, throat, or pharyngeal areas, while also aiding in the transition from mouth breathing to nasal breathing. The appliances, consisting of the TLJ, TLP, and lip trainer, are used to assist in alleviating sleep-disordered breathing problems and jaw joint dysfunction. The revolutionary Myotalia TLJ is an active myofunctional appliance used for strengthening the tongue, lips, and exercising the jaw joint muscles. The TLJ is combined with a series of exercises that target the throat and pharyngeal muscles, which are typically weak in patients who show symptoms of sleep-related breathing disorders. This is an essential part of myofunctional orthodontic and TMJ BDS treatment. The TLP focuses on strengthening the tongue and lips in a similar manner to the TLJ. However, its design allows for its use in combination with the MyoBrace and Myosa appliances for specific or transitional use. The lip trainer, which also includes the lip seal trainer, functions by strengthening and stretching the lower lip muscles to reduce overactivity when swallowing. The lip seal trainer serves as a tether for the lip trainer and helps to further improve lip seal.
Yeah, so there's a series of exercises that we do as part of our myofunctional therapy. And all my kids go through this as part of their orthodontic correction. But remember, I don't start this until after I know the jaw is widened correctly and after I know the tongue has been released, right? So this is really what they're doing to supplement what you people are doing. Right, so to summarize tonight's lecture, I hope you all understand now what a tongue thrust is. That's going to be one of your MCQs. It really is where the tongue moves forward during the swallow, either against or between the teeth. And what is a orofacial myofunctional disorder? It can be digit sucking, it can be an open mouth posture, it can be a forward rest posture of the tongue against the incisors. And these improper patterns can open the bite to beyond what is considered normal and can cause disruption of the dental development in children and overeruption of certain teeth in adults. So I've gone through the reasons that OMD may be caused. And the big one, of course, is airway. So what we want to do is look at these kids in a different light and work in a team to get that tongue resting on the alveolar ridge where the palatine rugae is. And we want to train the kid to breathe through the nose, lips together, tongue on the palate. So we use resting tongue posture, tactile and sensory biofeedback. And this is just by a small wafer on the alveolar ridge. Now, I used to use this, but the problem is this is really designed for external use, and you shouldn't really put it in the mouth. This is what I now use. It's called a MyoSpot, and I'm very proud to say that's an Australian invention by a group in Brisbane, and it comes in different flavors. It's easy to stick on, and can you see how the tongue can sit in the right spot because of that? So those stoma products, really, they've got a chemical polymer, and which is like a synthetic rubber. So you really should keep it external, not internal, right? Whereas the MyoSpot is perfect for that. So you clean the area, dry it, I mean, put the MyoSpot there, and then the primary aim of the therapy is to eliminate the harmful sucking habits, to retrain the tongue to rest in the correct position, to teach a closed lip posture, and to retrain that swallowing pattern, right? And there's a number of exercises that do that, which I don't want to get into at this stage. So the summary of what I'm discussing with you today, I hope you've enjoyed the lecture. I'm going to happily answer any questions. So if any of you have any questions, now's the time to just type them into Q&A. Housekeeping again, I'm happy to give you all the papers I've mentioned, all the videos I've mentioned. You just need to go to a website because my PA doesn't want to answer 500 emails. She puts it all in a Dropbox, and you can get all that Dropbox information by going to the website, which is, remember, eodo.teachable.com, right? Now, if for some reason you can't find it, you can contact my PA at Derek Mahoney. Remember, biggest error, people put an E, no E, derekmahoney.com. So my PA can help you. You can get a CPD certificate for this lecture by just doing the multiple choice questions. They're very simple. If you follow the lecture. Now, if you have friends that you'd like to listen to this lecture and they weren't able to watch it live, send them to that site. The lecture's available on there normally for another month, and they can watch it for free. They can get a CPD certificate. They just obviously don't have the opportunity to ask questions live. So, you know, it's all about fixing the airway, the nasal airway, so that the kid can put the lips together, tongue on the palate, breathe through the nose. They can't do that if their palate's too small. They can't do that if they're tongue-tied. So learn how to evaluate the width of a palate, learn how to evaluate a tongue-tie. Learn how to work with a good ear, nose, and throat doctor who understands this and who, if you send them a kid with grade 4 tonsils, is not going to say something stupid like, oh, I'm not going to do anything because they're not infected. That shows total lack of education, right? So I can help you, depending on what area you're in, to work with good ear, nose, and throat doctors. I can help you find people who release tongue ties the Zagi method, and you have to use the Zagi method. When you see his videos, you'll see why. As far as what exercises you do, there's no rule book. They're all developed by Dr. Garlinger many, many years ago, and they're exercises that just help the kid to put the tongue in the right position. And there's a lot of these videos that I have on my website, which I help parents navigate through, okay? All right, now, I wanted to talk for an hour and a half. It's pretty much including question and answers. So we can do maybe 10 minutes of questions and answers. Let's see how we go here. Right, so Alicia Briffa, can the myobrace and or the myotalia be used by hygienists without supervision of a dentist? If it's part of your myofunctional therapy, the answer for the myotalia is yes. The myobrace you cannot fit or recommend because it's an oral appliance. So that's definitely outside the scope of practice, right? So probably Nada would be the better person to answer that, but I know from my experience that I can recommend a myobrace, and as long as I fit it, then my myofunctional therapist can supervise its wear, okay? But you can't have it and fit it in the mouth because that would be a breach of the Dental Act. But as far as the myotalia, absolutely. I know a lot of speech processors who use that myotalia on a routine basis. It's just so simple to use. The exercises are on the app. It's really, really good. And you can get more information from the MRC website, www.myofunctionalresearchcorporation.com. Okay. Amy DeSantis, after attending this talk, I believe that some of my 6-year-old clients have these features. Is it too late to help, or would the approach be different? The only difference there, Amy, is that you may need an expansion appliance rather than just the tongue. So what I'm saying is before age 6, the tongue can be your expander because the sutures are wide open and it's easy to develop. After age 6, when the first molar erupts, that intermolar distance normally needs the help of an orthodontist to expand. So you can still do myofunctional therapy, but post-expansion. Whereas in under 6, the myofunctional therapy itself can give you the expansion. Does that make sense? Cecilia Chan, great refresher lecture for dentists. Great job rephrasing lecture materials for a different audience. Thanks so much. Well, thank you, Cecilia. That wasn't a question. That was your check's in the mail, Cecilia. Cecilia is one of my young dentists learning how to do good quality orthodontics. Nicole Hutchison. Hello, Nicole. Nicole's the person to see in Melbourne. She works with a wonderful pediatric dentist, Dr. Chan. Okay, she's asking, could you explain how to use the Bears questionnaire, please? Yeah, so Nicole, what you do, it's a screening questionnaire. So literally, to do the Bears questionnaire properly, there's questions that parents answers, and there's questions that you ask. There's one paper that explains how to do that correctly, and I'll just show you that paper right now. It's pretty easy to find. So let's go to our good friend Google. Now, the Bears questionnaire, and I hope you can all see this. I've given you the paper itself, right? But University of Pennsylvania have a really good summary on how to use it, all right? So that's the paper there. There's more papers than that, but that helps you to go through it correctly. And the more they answer yes, 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 so in other words, if they get 5, that's a high risk. If they get 0, it's a low risk. Anything greater than 3 is something that you need to keep an eye on. But lots of, it's a very good peer-reviewed, right, let's open this up. University of Washington probably can help you with the age-appropriate trigger questions. So in other words, there's the questions based on the age of the patient, right? So I prefer to do this with the parent, but you can also send it out to them. Hope that answers that question. Lost in screens. Stephanie Zuro, are your most recommended myo training courses the ones run by Joy Moll and Nada Crip? Look, there's so many on the market. If you're in Australia, Nada is fantastic because she works with a kid's dentist, Alina Blairs. There's also Rochelle McPherson, who works with a speech path to do great courses. Overseas, if you're willing to travel or do internet stuff, there's Barbara Coulson and there's Joy Moller. Now, let me tell you, for me to learn, I'm not just a teacher, I'm a student. I've done all of those courses. I've done Joy Moller's, I've done Barbara Coulson's, I've done Nada's, I've done Alina's, I've done Rochelle's. So they're all good. My advice, do all of them. But if you just want one, are you willing to travel? Are you wanting to do it through internet? They all have their pros and cons. But definitely Nada is more practical because she knows the Australian experience, okay? I'll punch her email up on your chat box in a minute. So this is from the Speechify team. Hi, Derek, thanks for the lecture. Looking forward to working with you. And I'm looking forward to working with you guys. How nice is it to find a speech pathology clinic in the same street as my practice? Normally I have to refer, parents like they want everything under one roof. I have a lovely lady who comes in to my Harris Park rooms named Marina Petrovic. I'll introduce you to her. She can help you guys navigate and get this part of your program. So yeah, so fantastic that we did this lecture. So another question, in Bowral, who does tongue ties? Look, I don't know every part of the world, but I can tell you that the best dentist in Bowral in early treatment is a lady called Lynette Wallace. Her practice is called something like Planet Smiles. Yeah, Planet Smiles, Lynette Wallace. That's your person in Bowral. Another question, should maxillary expansion be done before myofunctional treatment commences? Not in the under 6-year-olds. If you're under 6, your tongue is your expander. So your myofunctional therapy is your expansion. Over 6, yeah, definitely you need to widen the palate. Sometimes I get some extreme cases like cleft palate, definitely I need to expand even earlier, et cetera, et cetera. So really, it's, you know, the concept of widen the jaw so that the tongue has room to go up there, then make sure the tongue can go up there by making sure it's not released. Then you can start your therapy. Okay, so it's exactly 7:30. I still have a lot more questions. I'll do one more, but I've worked all day and I haven't eaten. So can you please email me your questions? I'll answer this last question from a Dr. Newen. Why does low tongue posture cause an open bite in some cases, but in other cases results in skeletal 3? Yeah. Well, okay, skeletal 3 can be genetic, meaning that the lower jaw is going to grow big anyway. The skeletal 3s I'm talking about are mid-face deficient problems where the tongue has not been sitting on the palate, widening the palate. Does that make sense, right? So you can have an open bite and still be skeletal 3. So remember, there's skeletal 2 where the lower jaw is too far back. You can have a deep bite or an open bite in a skeletal 2. The skeletal 3s where you can also have a deep bite and open bite. So it's not as though all class 3s have an open bite and all class 2s have a deep bite. The class 2 and class 3 is an AP problem. The open bite, deep bite is a vertical problem. So there's combinations of those. But the common dramas are the open bites in class 3s and the open bites in class 2s. They're the high incidence of the airway problems. But I can send you a paper if you just email me directly that talks about the type of obstruction relating to the malocclusion type. And that will answer that in more detail. All right, guys, thanks very much for your attention. I'll call it a wrap. And please come back on Teachable to review it, to read those papers. They're the papers I'll put there with the videos. I'll add a couple more like that Swedish paper for you to help you get it done. So keep safe, get vaccinated. Let's hope world returns to normal. I love lecturing in live audiences. Let's hope we can return to that soon. If not, at least this is a resource until we get there. So this is Derek Mahoney calling it a night.